Welcome to the series where I'll be discussing the 2026 Consensus Statement on the Algorithm for Management of Adults with Type 2 Diabetes by ACE. This is Endo in a Bite, where I break down endocrine concepts or lengthy guidelines into focused, high-yield pieces you can actually remember. For the full board-centric framework, I've built it all out in Easy Endo Prep, designed to keep you efficient, current, exam-ready, and sharp in clinic. Visit www.ezendoprep.com to enroll in the full course or start your free trial. When approaching diabetes classification, one of the most important reminders is that not every adult with hyperglycemia automatically has type 2 diabetes. Type 2 diabetes is common, but common does not mean universal. Adults may also present with autoimmune diabetes, pancreatic diabetes, monogenic diabetes, endocrinopathy-associated diabetes, medication-induced diabetes, or rare inherited syndromes. If the presentation does not fit the label, revisit the diagnosis. The first step is to confirm that diabetes is truly present. Diabetes may be diagnosed with an A1C of at least 6.5%, fasting plasma glucose of at least 126 milligrams per deciliter, a 2-hour glucose after a 75-gram oral glucose tolerance test of at least 200 milligrams per deciliter, or a random glucose of at least 200 milligrams per deciliter in the presence of classic symptoms of hyperglycemia. Those symptoms may include polyuria, polydipsia, blurred vision, fatigue, and unintentional weight loss. If the patient has no symptoms, repeat testing or confirmatory testing is appropriate before assigning a chronic diagnosis. Once diabetes is established, the next question is whether the patient truly fits a type 2 diabetes phenotype. Findings that support type 2 diabetes include overweight or obesity, keeping in mind that lower BMI thresholds may apply in individuals of Asian ancestry. A strong family history of type 2 diabetes is helpful. A prior history of gestational diabetes is helpful. Elevated triglycerides, low HDL, and physical findings of insulin resistance, such as acanthosis nigricans or skin tags, are also supportive. But phenotype alone should never end the conversation. Many adults with autoimmune diabetes may also have obesity. Some adults with true type 2 diabetes may have a normal BMI. So, appearance alone cannot be the deciding factor. Anchoring bias is common in diabetes care. Autoimmune diabetes deserves special attention. Type 1 diabetes is not only a childhood disease. Many patients are diagnosed in adulthood. Some present dramatically with diabetic ketoacidosis. Others present gradually and may initially be mistaken for type 2 diabetes. This slower autoimmune presentation is often referred to as latent autoimmune diabetes in adults. These patients may initially respond to oral agents, but over time, endogenous insulin production declines and insulin therapy becomes necessary. Clues suggesting autoimmune diabetes include a history of diabetic ketoacidosis, lean body habitus, absence of insulin resistance findings, personal or family autoimmune disease, family history of type 1 diabetes, or unexpectedly rapid need for insulin. Personal or family autoimmune conditions may include Hashimoto thyroiditis, Graves' disease, celiac disease, Addison disease, vitiligo, pernicious anemia, or other autoimmune disorders. Another increasingly important clue is checkpoint inhibitor exposure. Immune checkpoint therapy used in oncology can trigger autoimmune diabetes, often abruptly. When autoimmune diabetes is suspected, antibody testing is useful. This may include GAD antibodies, IA2 antibodies, zinc transporter 8 antibodies, and insulin antibodies. Remember that approximately 10% of type 1 diabetes may be antibody negative, so negative antibodies do not fully exclude the diagnosis. Also remember that corticosteroids or immunosuppressive medications may blunt detectable antibody positivity. Clinical judgment remains essential. C-peptide is another highly useful test because it reflects endogenous insulin production. Low C-peptide supports insulin deficiency. Preserved or elevated C-peptide suggests retained beta cell function, although interpretation depends on timing and glucose level. C-peptide should ideally be interpreted with a simultaneous glucose level. If glucose is very low, C-peptide may be suppressed. If the patient recently had severe hyperglycemia or diabetic ketoacidosis, repeat testing later may be more informative once glucotoxicity improves. When the patient does not fit classic type 1 or classic type 2 diabetes, broaden the differential diagnosis. Endocrine disorders can produce secondary diabetes. Hypercortisolism is a major example. Excess cortisol drives insulin resistance, central adiposity, hypertension, and worsening glycemia. If a patient has difficult to control diabetes with resistant hypertension, bruising, proximal weakness, or adrenal findings, consider cortisol excess. Acromegaly can present with worsening diabetes, enlarged hands or feet, sleep apnea, jaw changes, headaches, or carpal tunnel syndrome. If severe insulin resistance seems out of proportion, think endocrinopathy. Pancreatic diabetes is another important category. This may occur after chronic pancreatitis, pancreatic surgery, pancreatic cancer, cystic fibrosis, or hemochromatosis. These patients lose insulin-producing capacity because of pancreatic damage. They may have low C-peptide, negative autoimmune antibodies, earlier need for insulin, and higher risk of hypoglycemia. Some also lose glucagon reserve, which can make hypoglycemia more dangerous. Monogenic diabetes should also remain on the radar. MODY is one of the best-known categories. Think of monogenic diabetes when multiple generations are affected, especially in an autosomal dominant pattern. Think of it when a young person develops diabetes without obesity, without insulin resistance, and without antibodies. Diagnosis younger than 6 months of age strongly raises suspicion for monogenic neonatal diabetes rather than autoimmune type 1 diabetes. Medication-induced diabetes is common and often underrecognized. Glucocorticoids are classic offenders. Even short steroid courses can worsen glucose in susceptible individuals. Chronic therapy can unmask diabetes or markedly aggravate existing disease. Post-transplant immunosuppressive therapy may also cause diabetes. Checkpoint inhibitor autoimmune diabetes deserves separate mention because it may present suddenly, often with ketoacidosis, low C-peptide, and long-term insulin requirement. Mitochondrial diabetes is often maternally inherited and classically associated with hearing loss. If diabetes appears through the maternal line with deafness, think mitochondrial disease. Lipodystrophy should be considered when there is loss of subcutaneous fat, severe insulin resistance, very high triglycerides, and diabetes that seems metabolically extreme. These patients are often misclassified as routine type 2 diabetes. A patient labeled with type 2 diabetes who rapidly loses response to oral medications warrants a second look. A lean phenotype with evidence of insulin deficiency should prompt further evaluation. Recurrent episodes of ketosis suggest the need to reassess the underlying physiology. The presence of pancreatic disease should raise suspicion for causes beyond classic type 2 diabetes. Additional endocrine clues may be present. A family history of diabetes spanning multiple generations may point toward an inherited form of diabetes. Treatment responses that do not match the expected pattern should trigger reconsideration of the diagnosis. Step back and question the label. A diagnosis is only as accurate as the physiology behind it. When the classification is corrected, treatment changes. Autoimmune diabetes may require insulin earlier. Pancreatic diabetes often needs insulin with careful hypoglycemia education. Monogenic diabetes may respond to targeted therapy. Endocrine causes may improve if the primary hormone disorder is treated. Medication-induced diabetes may improve if the offending agent is reduced or changed. In summary, diabetes classification is not about assigning a label. It is about understanding the underlying physiology. While type 2 diabetes remains the most common diagnosis, clinicians must remain alert for autoimmune diabetes, pancreatic diabetes, monogenic diabetes, endocrinopathies, medication-induced diabetes, and rare inherited syndromes. When the clinical picture, treatment response, or disease progression does not fit expectations, pause and reconsider the diagnosis. Use the tools available, including history, phenotype, autoantibodies, C-peptide testing, and targeted evaluation, to uncover the true cause of hyperglycemia. The correct diagnosis leads to the correct treatment and ultimately better outcomes for our patients. Always remember, treat the physiology, not just the label. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, don't worry. I've prepared the notes for you. Visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam preparation. Remember, stay consistent, and together we'll work through the ACE consensus statement on the algorithm for the management of dyslipidemia, one bite at a time.